Welcome back, everybody. This will be the first of two talks on the glomerular disorders. These are disorders that happen at the level of the glomerulus, which is the beginning of the nephron. Now, in a previous talk, I talked about tubulointerstitial disorders, which is where it affects the tubules, which is a different part of the nephron. So here we're talking about disorders that affect the glomerulus. And as we're going to see, there is a lot of overlap with these glomerular disorders with the vasculitides. And the reason is because a lot of those vasculitides, Wagners, Churg-Strauss, they affect small vessels. And where do we have small vessels? We have small vessels in our kidneys. So that will be a part of this talk, even though I do talk about it also in the rheumatology videos. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos. And I thank all those of you who have already donated. Definitely subscribe to my channel and you will get notifications every time I put a new video up. All right, so this is just a kind of an overview here. Glomerulonephritis or glomerular disorders is a term that refers to a set of diseases that involve inflammation and damage to the glomerulus. So remember, you have afferent arteriole, efferent arteriole, and then this sort of tuft of capillaries. And then here you have Bowman space, and then this will give to the tubules. And I'm not drawing it right here, but this is tubules. Remember, you got your proximal convoluted tubule and loop of Henle and all that. So here we're talking of a disorder that is located right here as opposed to down here. Now, the triad that's classically associated with glomerular disorders is hypertension, edema, and hematuria. But this is more something you're going to see in nephrotic syndrome. And not all of these lead to nephrotic syndrome, so you can't always rely on that. However, hematuria in an otherwise healthy patient or in a patient with other symptoms should lead you to consider glomerular disorders. When you do your urinalysis, it will show the hematuria. That hematuria may be present in red blood cells that are visible in microscopy, or it may be present in the form of red blood cell casts. And in my intro video, I talk about casts. So you can also see proteinuria to varying degrees. Some of these can cause a nephrotic syndrome where you're losing a ton of protein. It's going to cause an edema, going to cause hypertension. Some of them not so much. If you do have proteinuria, you need to get a 24-hour urine protein to establish whether this is a nephrotic syndrome or not. You can also get a protein creatinine ratio, and you should also get a lipid panel. BMP will show a BUN creatinine ratio of 10-1 roughly. CBC is variable. SED rate is nice because it tells us maybe there's something inflammatory going on. And then the serum C3 or complement is going to be either low or normal, and that will help with the differentiation. Okay, so when you have substantial protein loss, meaning more than 3.5 grams per day, you can start to develop these very specific symptoms. So because you have a high amount of protein in the urine, which you may detect on your analysis or in the 24-hour collection, you'll have this frothy urine. That is a common word that's given to say, hey, this person's got proteinuria. This person may have a nephrotic syndrome. Then because you're losing it in your urine, you're going to have a low protein in your bloodstream, and that's going to lead to peripheral edema. Decreased oncotic pressure is going to push fluid out into the tissue. And then you'll have an increased catabolism of lipoproteins, which is going to lead to a hyperlipidemia. That's why we get those lipid panels. And then damage to the glomeruli at a low GFR can activate the RAS pathway, increase your aldosterone. That leads to more fluid retention, and that can also lead to a hypertension. Okay, so these things really point to a nephrotic syndrome, but the only way is a 24-hour urine protein collection. That's the only way we're going to know for sure, because nephrotic syndrome is defined based on the amount of protein you're losing per day. Okay, and this kind of just goes over what I talked about. There are some of these glomerular nephropathies that are more likely to cause nephrotic syndrome than others, and we'll get to those. This is a comparison between the tubular interstitial and the glomerular disorders. What I really want to draw your attention to here is the debris, red cell casts instead of muddy brown casts. And then hematuria and proteinuria are much more common in the glomerular disorders than in the tubular interstitial disorders. Try saying that 5 times fast. So the reason here is that, yeah, you got red blood cells and you got proteins going through the glomerular capillaries. But if the damage is at the tubules, well, there's really no red blood cells to seep in there. So you're less likely to lose blood and protein with a tubulointerstitial disorder. Okay, so these are casts, and I go over this in my intro video. What are these here, these two? These are red blood cell casts. So this points to a glomerulonephritis, or glomerular nephropathy. What's this here? This is a muddy brown cast. And this points to what? Acute tubular necrosis. Totally different disease process. Okay, so we are going to start with the systemic glomerular disorders in this talk, and then in the next talk we will do the renal only ones. And a lot of these I talk about in different sections, so I'm really just going to hone in on the renal implications here. Okay, GPA, or Wagners granulomatosis, is a vasculitis that primarily affects medium and small vessels, and it's characterized by prominent renal, respiratory, and skin involvement. And it's the respiratory that's going to give this away on an exam. So these patients will have recurrent, non-infectious sinusitis. They get inflammation just due to the vasculitis. And so they constantly have a stuffy nose, maybe have a deviated septum or a perforated septum. They can get these deformities to their nose, saddle nose deformity, like I said, septal perforation. So look for these really salient upper respiratory tract symptoms. They also can get renal failure. However, most of these patients, when they come in for evaluation, when they've got symptoms consistent with GPA, they're not going to have renal failure. The best initial test when you suspect GPA is a C-ANCA. That will be positive in most cases. And on CBC, which of course should be part of your general workup, you're not going to see eosinophilia like you may in the next disease we're going to talk about. The most accurate test is a renal or a lung biopsy. Remember, both of those organs are affected. The treatment is prednisone and rituximab. These are some of the other systemic findings you can see in GPA. As you can see, there are a lot, okay? I would also focus on these cutaneous signs, these palpable purpura. When you see that in conjunction with, chronic upper respiratory tract issues and constitutional features, you're really looking at GPA. Okay, EGPA, or Churg-Strauss, is basically GPA with asthma. Okay, there's not really a whole lot of differences. These are basically GPA patients who have allergy, and it's a prominent feature. So otherwise, things are pretty similar. So you're looking at a similar patient presentation, but maybe they have a history of asthma or they have a history of eczema. So in this case, you're going to get a P-ANCA, okay, a P-ANCA. And that will be positive in most cases. If you get a CBC, a lot of times, if you look at your differential, you'll have an eosinophilia that also supports the diagnosis. Biopsy, again, most accurate. The treatment here is prednisone and rituximab. There are other drugs you can use, one of them being mepolizumab or Nucala. This is an IL-5 inhibitor. And by doing that, it reduces sort of that allergic reaction, to put it really, really, really bluntly. It's not the best explanation, but basically it does work on that allergic process. This is also given to patients who have asthma with eosinophils. Good pasture disease is characterized by isolated renal and lung involvement. So these patients are only going to have renal and lung symptoms. They're not going to have any palpable purpura. They're not going to have constitutional signs. It's just going to be the glomerulonephritis, and maybe they're coughing up blood. Okay, so microhematuria and hemoptysis. You can differentiate this from GPA and EGPA in that there's no other features besides renal and lung. There's a slight male preponderance, but it's not very much. Pulmonary symptoms usually present first, so cough and hemoptysis. Look for this on a test question. As a 25-year-old guy coming in, he's got a cough, and now he's coughing up blood. And you might be thinking, oh, TB. Good to work up. But good pasture is another one that may be there. Make sure and get a urinalysis. You see blood in the urine, you got your diagnosis. Best initial test is anti-GBM antibody titers. And to treat this, we do plasmapheresis, prednisone, and cyclophosphamide. Polyarteritis nodosa is a small and medium vessel vasculitis that's characterized by multisystemic symptoms, but these tend to spare the lungs. And it's also often associated with abdominal pain. Now, there's an increased incidence in patients with hepatitis B, but certainly not all of them. There are some unique things to look out for here because this tends to affect small vessels. Look for livido reticularis, or that kind of modeling pattern on the skin. And then there may be some motor sensory neuropathy and pain. So classically on the USMLE, this will be a person with established hepatitis coming in with fatigue, weight loss, and abdominal pain. Of course, you should get a CBC, a BMP, a urinalysis. You get that urinalysis, you show red blood cells in the urine. You are looking at polyarteritis nodosa. The best initial test is an abdominal angiogram, although there's disagreement there. The most accurate test is a sural nerve or renal biopsy. There is no disagreement there. The treatment is prednisone and cyclophosphamide. TPWDHUS I go over in my hematology videos, but this is a pentad. You have microangiopathic hemolytic anemia, which leads to jaundice and fatigue. You have a consumption thrombocytopenia, which is basically due to the platelets sticking together and you can't get them separated. So you have a lot of platelets in your blood, but they're all clumped up together. That can lead to platelet-type bleeding. You can also have fever, renal dysfunction, and neurological abnormalities. In a patient vignette, look for an HIV patient, a cancer patient, look for a kid that had a recent enteritis. Those are all classic for developing TPWDHUS. So on your lab, CBC will show low platelets and anemia. Peripheral smear will show schistocytes, and urinalysis will show microhematuria. Again, go back and watch that video if you haven't yet. Treatment here is supportive. We do not give antibiotics or platelets. We're just going to cause more problems. Antibiotics are going to spill more toxin into the bloodstream. Platelets will just cause more thrombosis because the same thing's going to happen here. What you can do is you can consider plasmapheresis or fresh frozen plasma if there is significant bleeding. But otherwise, this is fairly well contained. Diabetic neuropathy is a complication of poorly controlled diabetes, which causes damage to the glomeruli due to glycosylation. The patient will usually have hypertension, often unrelated hypertension, and because diabetics are supposed to come in and get routine urinalysis, what you'll often see here is a very high protein. So instead of a microalbuminuria, you're going to see very high protein concentration. You go on to get that 24-hour urine protein, and you find it's quite high, possibly even in the nephrotic range. Diagnosis is based on history and labs. To treat this, you just control the underlying causes. So we've got to get the diabetes under control. So diet, exercise, and strict glycemic control. Get your A1C checked every 3 months. If we're not getting it under control, then maybe we need to switch the anti-hyperglycemic medications to get the A1C into an optimal range. For hypertension, ACE inhibitors. Membranous glomerulonephritis, otherwise known as membranous nephropathy. This is idiopathic, but it is one of the most common causes of nephrotic syndrome among white adults. So if you have an adult patient coming in with nephrotic features, especially if they tell you it's a white adult, you should be thinking of membranous nephropathy or membranous glomerulonephritis. If it's a child, you should be thinking of minimal change disease. Okay, so on history, we may not know the cause, but it is associated with malignancy, breast, lung, and colon, which are very common cancers, can be associated with infections and also autoimmune disorders. So you treat this, but then you want to kind of maybe work these patients up for something else. Symptoms, nephrotic features, diagnosis. Of course, the urinalysis will show 4+ protein. Get the 24-hour urine protein. It'll be more than 3.5 grams. The patient will show features of nephrotic syndrome. If no cause is apparent, at least what you want to do is get hepatitis panels and ANA. Hepatitis panels will tell you if it's due to a hepatitis. ANA will screen for a lot of autoimmune disorders. You could probably even add in rheumatoid factor and so forth. Treatment, it's symptomatic. Control the hypertension with ACE inhibitors or ARBs, low salt diet. With hypercholesterolemia, we go for statins. Amyloidosis is due to deposition of amyloid protein in the various tissues. It can be AL amyloidosis, which is usually associated with multiple myeloma, light chains, or it can be AA amyloidosis, which is usually associated with chronic inflammation. Basically, what's happening here is that you have deposition of this amyloid protein and it interferes with the nephron's ability to do its job. The best initial test when you suspect amyloidosis is to get a fat pad biopsy. That will show the amyloid tissue. It's easy to get. And you stain with Congo red, and it'll show this so-called apple green birefringence, which you should know as a $100 term because it comes up all the time. You should knee-jerk associate that with amyloidosis. And the treatment is to control the underlying inflammation, and it is usually inflammation. Elport syndrome is usually X-linked. We tend to see this in little boys. It's a disorder of type 4 collagen, which remember forms the basement membrane. And the two most important places that basement membrane exists is in the ears and in the kidneys. So you can get sensory neural deafness or hearing loss. You can get gross hematuria. You can also get visual deficits. So look for, on an exam, look for an 8-year-old boy coming in who's peeing out blood and he is deaf. Okay, or he was told at his routine hearing screen at school that he's got poor hearing acuity. So this is kind of what you might run into on a test. So a young boy who's hard of hearing, a young child who's hypertensive and edematous, if it's bad enough, a family history of deafness. Remember, this is usually X-linked, so usually a boy. Look at the mom's family history. However, it can manifest in girls just to a lesser degree. So if you do suspect Elport in a girl, look for either parent. And then it could present as an abnormal urinalysis that shows proteinuria and microhematuria, but usually there will be these associated symptoms with Elport. The treatment is to manage the hypertension if it exists with ACE inhibitors, advise the patient and the parents of the possibility of nephrotic syndrome, and these patients usually go on to develop renal failure by late adolescence, early adulthood. IGA vasculitis or Henoch-Schönlein purpura is very common. It's a small vessel vasculitis that's characterized by some systemic signs like arthralgias and fever, and this very characteristic rash where you get these multiple red-violet palpable purpura that if you press on them, they don't blanch, and they have a predilection for the legs and the buttocks, and they also have prominent abdominal pain. This is almost always seen in children and adolescents. So look for a kid coming in with abdominal pain and a rash. You get a urinalysis and you see blood in the urine. Diagnosis here is clinical, but the suspicions are confirmed on the urinalysis, which shows microhematuria, red blood cell casts. If there is renal involvement, we call that IGA nephropathy. Henoch-Schönlein purpura does not always have renal involvement. That's why I say this diagnosis is clinical. However, you want to get the urinalysis because that will tell you whether or not you're dealing with IgA nephropathy. Treatment, generally not needed. So this is what you see here. You can see very obvious lesions here, and they tend to be on the legs and buttocks. Okay, Cryoglobulinemia is associated with Hep C, and this is one of the few that's going to give you a low complement. Okay, those cryoglobins, they will attract complement and use it up, so you'll have a low complement. The main differential here is Henoch-Schönlein purpura. It looks very similar because of the skin lesions. However, patients with cryoglobulinemia have low complement levels. Henoch-Schönlein purpura, normal complement levels. Symptoms, already mentioned. Diagnosis, serum cryoglobulins. Make sure and get hepatitis panels, and the C3 will be low. The treatment here is to treat the underlying cause. Symptoms can be treated with prednisone and or rituximab. Lupus nephritis. This is a multisystemic disorder characterized by our classic lupus symptoms, the malar rash, constitutional signs, joint pain, especially in young women. There is an increased incidence in black women, and USMLE loves to go at that, along with sarcoidosis. They are kind of obsessed. But keep in mind that only a minority of lupus patients will present with renal symptoms, but the majority will go on to develop them. Symptoms, look for associated features with lupus. Renal manifestations can vary anywhere from nephritic to nephrotic, so get your urinalysis. If you suspect lupus nephritis and you haven't diagnosed the patient with lupus, go about that. So how do we diagnose the patient with lupus? We start with ANA. If ANA is positive, then we get the more specific markers, anti-dsDNA and anti-Smith. Those come back positive, boom, you've diagnosed lupus. Once you've done that, then you need to get a renal biopsy. Why? Because it guides treatment. So the treatment is based on the biopsy. You can read this here. I doubt this is going to come up, but just know that if we do have to treat lupus nephritis, it's going to be done with steroids and mycophenolate. This is the malar rash. And these are the symptoms prevalence at onset in lupus. And then this is a recap.